Hello everybody, I'm Thelma Thomas, GP by background, and some of you may remember me as a GP in Ealing quite some time ago now. Currently I do some voluntary work with Doctors of the World clinic in East London. Doctors of the World UK is part of the International Médecins du Monde network. And we're an organisation working in the UK. Our work is based on improving access to primary care for people in vulnerable situations, and that's the topic I'll be focusing on today. Just moving aside. So today I'm hoping that we will be able to cover number of aims, achieve a number of aims. Going to understanding entitlement to NHS care in England is quite a challenging topic. I hope to present an introduction and to just outline the most important factors when considering access to NHS care in terms of primary care. I'll be talking about the barriers faced by migrants in particular, but they're equally applicable to other potentially excluded groups accessing particularly primary care. Hopefully provide more evidence for why good practice is needed to improve access in NHS care, and hopefully to enable to talk more confidently about why access to healthcare for migrants is so important. And I'm also going to introduce the Doctors of the World Safe Surgeries initiative. I'd like to start by saying a little bit about our clinic in East London, currently just beginning to reopen. I don't know for how long. We've been carrying out working remotely since March, and I've been involved in online consultations while the clinic has been closed. Let's just hang on a second as I'll just go back into the presentation here. Let's see. Can you still see the presentation? It seems to have jumped. Yeah,
Thelma, it's just
it is still there, is it?
No, it's gone at the moment.
It has gone. I'll just see what happens, and then otherwise I can talk you through. Right, let's have a go. Yep, okay, we'll be back on in a minute. Let's see. Give me a minute and I will re-find the presentation, which has totally disappeared from my... No, it does seem to have disappeared. I'll just need to reload the presentation. Danny, I don't know if while you're doing that, can you get anything up for me? That shouldn't take a moment.
Yeah, what do you want? I don't know
if you just get up with the slides as we go. It's a new one, actually.
Yeah, I've got the one Yusuf sent. I don't know if they're the most up to date.
No, I'll swap back in once this just reloads. It should come up. But if you could just take me to about the third, I think it's about the third slide, and I'll reload here. I hope. Yeah.
Is this slide the right one?
Yes, we could start there, and I'll just right. That's great. So I'm going to talk about the clinic in East London, where we are a clinic that shouldn't exist really, because the main aim of the clinic is to support people who are difficulty in accessing primary care. So we act as an advocacy service for GP registration, and also the backup team, Doctors of the World, also carries out advocacy work for secondary care. So the clinic in East London is staffed by support workers, and we have a clinician, GP or nurse, on site for most of the clinics. So people who come have either been unaware that they're allowed, that they can register for primary care. The majority of cases have had some other difficulty in registering. Support workers help them to register, telephone practices, and if they have immediate health problems, we provide an immediate health triage service, giving some health advice, having quite long conversations often with people with multiple health problems. We may then help, particularly if we've used an interpreter, to summarise, providing the service user with a letter to use for registration. Bear with me a moment, I should be able to go back into the presentation in just a second. Sorry about this. Slideshow. I'm just going to start from the beginning for ease of access. And Danny, I think am I there with you now?
Yeah, you can request control back, or I'll stop sharing now and then you can start.
Okay, if I could start sharing now, because it seems to. Do you have the beginning, the first slide up?
I've stopped sharing, so you can share if you click on the square with the arrow going through the middle.
Right, yes, so I'll just go back into the. Sure. And it does take a moment to load.
Yep, we can see the slides.
Excellent, good. And I'll just prop them forward. Okay, sorry to click them forward. It was just an easier way to do it.
Looks like the slides have gone again, Thelma.
Oh, dearie me, that is bizarre because they're still up here. Let me just see if it's a sharing option or not.
Yeah, it should have the red border around it if it's sharing the slides.
Hang on, let's just go. That seems to be. I have no idea what's happened there. That's a new one.
If you want, you can email them to me if you want, and I can quickly just put them up.
Don't worry, we'll go with the ones that you've got, Danny. If that's okay, I can talk through the one important change and then send them afterwards, if that's okay. So I'm going to leave it with you, if that's okay.
Yep. So let me know when to go to the next one.
Right. Yes. If you can just move now. Hold on. Let me see. And then I'll just get them up so I know where we are. Right, which slide have you up at the moment, Danny? Is it the primary care clinic in East London?
I've moved on to the next one, which says 2,000 visits, 62%.
Okay, right. Actually not seeing any of them at the moment. Oh, very strange. Okie doke, don't worry, I'm just going to. Right, yes, okay, sorry about that. Okay, so just quickly to cover the work that we do in the clinic when it's open and currently remotely. That's even better. See what's happening. Okay, so in 2018, we had about 2,000 people through the clinic, with a further nearly 7,000 telephone contacts from the office. 62% of the people that we see are undocumented. The rest mostly are migrants, asylum, mostly are refugees and asylum seekers, or have had other difficulties in terms of accessing primary care. Interestingly, the population that we've seen in the clinic in 2018, average time they'd already spent in the UK, mostly without any access to healthcare, totally was 5 years. We see some people who've been here for 10, 15 years, and others who more recently arrived. We have an STI screening service. We signpost people to other non-medical services, but most important part of the work in the clinic itself is to actually enable people to register with primary care entitled. We are obviously very highly aware of the need to take history of violence in the past. Don't always do it, but we had 300 of our clients in 2018 told us about violence they had experienced either in their country of origin, on the way, or on the journey here, or indeed while they've been in the UK. If you can just move on, Jenny, please. We run a separate session for once a week for pregnant women and children, and we've saw nearly 1,000 women, of whom about a quarter are pregnant, and the average stage of pregnancy, when they reach us in the clinic, they're average already 15 weeks pregnant. So they are, even if it takes a week or two to book, they're obviously late booking, late into antenatal care. Okay. Here. Okay, so terms, before we sort of start looking at entitlements, why are these terms important? And the simple answer is that obviously when it comes to charging secondary care services, it is important. And this is a simplified version of a complex situation. Essentially, as you're all aware, an asylum seeker who's left their country of origin, applied for asylum, and the claim is currently being looked at. And so while they're actively seeking asylum, they are entitled to full NHS care. Refugees, someone whose application has been successful, and they have, whether for limited or unlimited, a right to stay, and so they are entitled to full NHS care. Refused asylum seekers, someone whose asylum seeker application has been unsuccessful, and the minute it's been unsuccessful, any rights that you had before are then changed into the limited access to healthcare. Undocumented migrants, someone who enters or stays in the UK without documents. And I think it's important to make the point that actually you can only apply for asylum from this country, or not sure whether we've still from Calais, but certainly it's not something you can do before you leave your own country. That's quite an important, and we'll talk in a little bit about the fact that people who, on arrival, don't necessarily know that the first thing they should do is to claim asylum. Some may not, or many are not actually aware of any of the processes that are needed. Okay, so just I'm going to be very quick. We won't have time today to look at many case studies, but just to take the case of a sort of built up a compilation of pictures, but it's not an unusual picture that we have 28-year-old women fleeing Eritrea, reading conscription, details unknown. Came through Libya, spent time in Libya, in prison in Libya, managed to get out of Libya, arrived in Italy where she was street homeless, victim of sexual assault, is taken to Calais, gets across to London, where for the first two months she is actually street homeless, until she's befriended and picked up, taken to a church by someone she meets in the street. And I think it is one of the sort of interesting things is to hear how people are assisted and how sometimes from people within their own community, but often from others, and offered refuge and taken to places of safety. And so from there she actually came to Doctor of the World Clinic. So her immigration status, if we can just move on, Danny. So she is actually one of the undocumented migrants, and just interesting to look at who are undocumented migrants, because there are a number of reasons that people find themselves without the right documents, many of these reasons are beyond their control. So people, I've alluded to, the people who arrive in the country don't actually have a clue about asylum, the need to seek asylum. They've obviously been brought often under false pretenses, on the offer of jobs, some very specific jobs. Someone told me how he'd been offered a job was told he'd have a job in the Merchant Navy when he arrived, and rather poignantly just turned to me and said, but when I arrived, he said, there were no ships. Refused asylum seekers, again, I've mentioned those. People who come to the UK to work without a visa, often turned economic migrants. They're people who've left their own country in the belief that they will have opportunities elsewhere. Quite a number are, we see, have actually come because they have got into debt for whatever reason. Then the loan sharks come, maybe beat them up, or sort of assault them in some way, threaten them and their families, and then of course come up with but don't worry, if you come with us, pay us some money, we will get you to a country where you'll be able to work and make plenty of money, repay your loan. And of course that is not what actually happens. People whose visas expired, students, working visas, and people come, may finish their course, decide they want to stay, may not finish their course. Sometimes colleges are being closed. Important group, domestic workers, we see quite a lot. We do a pop-up clinic and for justice for domestic workers. So there's a large group, predominantly Filipino, mainly women, have come to the UK, been brought by families, sort of ill-treated, lengthy working hours, no pay, poor pay, abused, and have left their working situation, or their employers have not renewed visas. Spousal visas, relationships break down, and then of course the group we're all familiar with, Windrush generation. People came to the UK as children, or even as young adults, have never actually been documented. And of course, big important group, survivors of trafficking, and I'm sure you're all well aware of the need to be aware and to look out for people who might have been trafficked, and who may or may not want to disclose to you that they have been trafficked. Okay, Danny. So accessing healthcare, if we can move on. First of all, the barriers, and still people are asked for ID and proof of address. We'll come back to that. Still they might be asked, and our case support workers are asked when they ring, the questions about immigration status, which we know should not be asked. There are also other barriers. Language is often a barrier, and they may well also not know that they are entitled to primary care. And fear of arrest and data sharing is a very real worry too. Okay. Right, so this is a slide, actually, if you can just ignore the bottom bit, because there's a much better bit which we'll put in the new slides. During COVID, the impression has been, let me put it, that many practices aren't registering new patients. Now, I'm sure all of you here know that's not true, but unfortunately, a lot of the messages have been interpreted that there is no registration. But this is because the lengthy messages on telephones often start with the "do not come to the surgery," and so the impression has been given, and indeed case support workers have reported that it has been increasingly difficult to register people. Digital exclusion has really been a sort of an area that I think has obviously not been so important in the past, but is very much something that I think we need to remember when allowing people to register. The information that's not on this slide is that Doctors of the World, if you go to the look on the website under the resources for medics, there's a number of resources, but one is new toolkit with 8 steps to help people, to help practices to help people who may have difficulty registering. I'm going to run through them quickly, but they will be available on the slides when I get the new set to Danny. So firstly, the obvious one, continue to register new patients during the pandemic, and secondly, don't be insisting on photo ID and proof of address. Try and identify and reach out to people in vulnerable circumstances who are at high risk during the pandemic. Supporting people with access to their medication, in particular, this comes into another point in the list, which is about keeping patients registered. As you know, both homeless and some of the asylum seekers are being housed in hotels. They have been, they don't know how long they're going to be there. They may be moved on. If it's possible to keep them registered during this time, particularly in terms of supplies of medication, this is a really helpful and useful policy. Don't forget to look, as with all interactions with vulnerable groups or people in vulnerable situations, and as well as with other patients, to conduct risk assessments of domestic abuse and violence. We know that it's increased during lockdowns, and we know that lockdowns are currently, if not fully there, certainly we're on the way to potential lockdowns and less movement out of households. Also, and again, this is all sort of common knowledge and general practice, the importance of prioritising face-to-face appointments for people in vulnerable circumstances and at higher risk. And finally, guidance for potentially excluded groups, and draw your attention to the fact that Doctors of the World has translations of some basic COVID advice, translations in 60 languages available on the website. Okay, keeping half an eye on the clock. So back to the Doctors of the World. Figures from 2019. Why are we doing? Why do we see the need to actually to do webinars and to talk about the Safe Surgeries initiative in a bit, and clinic attempts at registration, phone calls to GP practices, and 2,873 attempts. This is not obviously number of patients, as some needed 2 or 3 attempts. Just over a quarter were actually refused, and refused sometimes because obviously registration was closed, was correctly closed, but often because of other reservations, and people saying they need proof of both ID and residence, and policy not to accept anyone without documentation, not willing to register, keep asking. These sort of, I think you can see the flavour of the reasons that are given for not registering. If we could pop through next slide, thanks. So I'm going to just be very, going to say, correct and just remind everyone, I'm sure you're all well aware of this, and I apologise. The guidance on registration make it very clear nationality and immigration status are not relevant to registration. Anybody may register and consult without charge. Key here too is that all asylum seekers. Hello?
Because now it's not really.
Hello, someone's not muted, I think. Okay, so all asylum seekers, whether lawfully in the UK or not, so people who, anybody here, lawfully or not lawfully, are eligible to register with a GP practice, and the patient does not need to be ordinary resident. Next one, Jenny, please. Thank you. So, no regulatory requirement. So while it's perfectly reasonable to ask everybody, do they have any ID, refusing on basis of no proof or address or ID is not considered reasonable grounds. And I think many of you will have been to the series homelessness workshops that were run in Ealing last year, where solutions such as using the practice address or the address of a voluntary organisation were cited as possible for those who either could not or would not give their address. I think it's still a fairly, we have very few service users who won't give an address, because obviously it usually is necessary and useful, but obviously people who are homeless are very mobile. It is difficult to have, for them it may be difficult to find an address to use. Okay, Danny. Okay, and sort of technically, I think often, of course, it's not, practices don't actually have the name when they're talking to the caseworker. Technically, a record should be kept of refusers, but in practice, I think it's rare that the full details are actually given at that stage. It's just worth flagging up that it is in the guidance. Okay, Denny, thanks. Okay, so what about the guidance during COVID? Continue to register, and I think the key thing here is also to remember the difficulties resulting from digital exclusion, and to take this into account and to make appropriate changes so that applications can be popped through the letterbox and telephone contact made, because as it states very clearly here, and we're talking about change in access may disproportionately affect certain patient groups, and it's important that practices are aware of this and take measures to ensure that they're not restricting access. Translation interpretation may well, translation services may well be needed. Danny, thanks. Okay, anything up in the, I actually had the chat box and I haven't seen anything up so far, unless anybody wants to raise anything. I am conscious of time, having through my lots of presentation, but happy to take any quick points of clarification. Any at the moment? No. Okay, so the Safe Surgeries Initiative. This introduced in 2018 and brought in, I think, the background. I think you could understand why it was felt that we could do more in respect of sort of supporting, educating practices. And if I can move on, Danny. Thanks. So safe surgery, and a safe surgery is a place where people can register safely, knowing that their care, their privacy will be safely maintained. So it's not a reference to safety in the sort of conventional safety. It's not implying that other safe practices are not safe. So it's a practice which commits and taking steps to tackle the barriers to healthcare faced by migrants and is prepared to join the network of safe surgeries doing this. So it's a supportive national network, support staff, learning, skills building and visibility and recognition. So what if the advantages? I think I should stress that actually the resources Doctors of the World and the advice service Doctors of the World for any health, for any practices needing help in terms of understanding entitlement to care, obviously that's open to all practices. Safe Surgeries Network have access to posters, to leaflets and to training. We're happy to come and talk to practices and have sort of more interactive sessions talking about any of the challenges in registration or providing care, sort of challenges that occur when, as we know, we can provide free primary care, but we know that secondary care, we have to refer to secondary care service where charges may be incurred, and I will talk a bit about that later. So next slide, Denny, please. So health is not a luxury, so it's an inclusive, protective. So leaflets and the toolkit, if you could just move on, Danny, please. Here we are, 7 steps for safe patient registration. Sadly, it starts with a negative, so sort of shame. We've talked about not insisting, no, proof of ID and proof of, or rather ID and proof of address, not essential. And of course, immigration status is not a piece of data that should be, is required. Keeping information safe, and that's common to everyone. Use of translation services, posters, and particularly the frontline staff, empowering the frontline staff and receptionists so that when there is a request from someone who may well be scared, struggling with English, that they feel they know what to do. You know what to do, how to handle it, and can display a positive and welcoming attitude, which is not easy when you're unsure about rules and regulations. Okay, so just a quick whisk. There are to just in Ealing, we already have between a handful of safe surgeries, and more across London. I think the quick answer is SAPNO is yes if it's for a sort of a new condition, but we can answer questions in more detail after the meeting. But so quick answer for now is yes, and we'll take you through that a little bit more. Okay, Danny, sorry, next one. So across the country, more than 340 safe surgeries, and more slides. So I think I've said why become a safe surgery, but also I'd like to comment on, I think, because it makes you smile according to the publicity photos that we have. But NHS policy, it ensures that you are complying, CQC approved, helpful reception, time management, communication, and of course improving patient experience. Yes, next slide please. Okay, it's been listed as an evidence-based intervention in the NHS long-term plan, so it's very much part of or smiled upon by NHSE. Next one please, Danny. And here we are, the smiling faces, if we can pop through again. Right, to sign up for safe surgeries, you can do it now, or you can sign up the website. Website showing here, and hopefully you might be able to gather together, encourage others to sign up, maybe hold a training session with other practices in the networks, and discuss the issues that are coming up, which are not, I think we have to remember that most surgeries, this is not a situation that happens every day, and so it is helpful to discuss and to learn from others that often the people are coming, particularly haven't had any healthcare, come with multiple problems. And I certainly, when I'm talking to people in the clinic, I do try and remind them that unlike the leisurely conversation I'm able to have, a GP's appointment will be 10 minutes, and we can sometimes help them to prioritise their health problems, and particularly to understand that not everything will be dealt with necessarily in one sitting. Can just move on. Okay, I thought I probably just got time to whisk through some points on secondary care charging, which is obviously a big hot potato. The most important thing for primary care to remember is that practice must always refer to secondary care. Immigration status or concerns about charging should not stop you from doing the referral. We talk in the clinic, if this does come up, and particularly comes up with us with antenatal care, where we try to encourage and remind the woman that the most important thing is to go for the antenatal care, and that, you know, how important it is, and that charges will come. We'll come on to this. Will come later, but that this should not deter them from going. So some restrictions to some services, some are free, and as we know, the overseas visitors managers work out entitlements, although I will be stressing in a minute that the decision on who is entitled is actually still entitled to free care is actually a clinical one. If we can just move on, Danny. Okay, so just to look at the restrictions. So particularly apply to undocumented migrants, including refused asylum seekers. So if you refused asylum seeker, but you plan to make a new application, pending that application, you are not entitled to many secondary care services. So in some cases, charges must be paid before treatment. However, some services are free. A&Es, you know, are free. A whole list of communicable diseases treatment is free. Family planning and COVID-19 test and all treatments are all free to all. Urgent or immediately necessary treatment has to be given, and this is a decision, it's a clinical decision. If a clinician decides it's urgent or immediately necessary, it must be provided before any billing is done. So the treatment goes ahead and the trust has to follow up with charging and what to do about charging after the treatment. It's important to understand that that is how it happens in secondary care. Next slide, please. Okay, so exempt from charges or refugees and asylum seekers. Refused asylum seekers, a small number are actually receiving the Section 4 destitution support, not a large number, but they are. Survivors of trafficking, while their case is being considered, and then if they are granted often limited rights to stay afterwards while they're maybe processing or putting in an asylum claim. So during that process, they are entitled to free care, children looked after by local authority, people treated under the Mental Health Act, all health care while they are being treated under the mental health care section, they are entitled to care for their other illnesses as well as mental health. People in immigration detention centres, and treatment that is caused by sexual or domestic violence, FGM or torture. Specifically, it has to be, but it's only treatment that can be directly attributed to the violence, and which obviously is a slight limiting factor there. But I think it's an important thing because if you know that that is the treatment you're referring for, and the patient knows that you are doing a referral and understands that the importance that you will mention it in a referral letter. Next slide, please. Okay. So I've stressed the need to refer rather than exclude at that stage from. And we know that hospitals have teams who will work out patient care. So just next slide, please, Danny. That doesn't tell us anything new. Here we go. So I think, sorry, this is of course, this is a set that had the duplicate slides. If you can just go on, Danny, please. I think the next one's duplicate and the other. Okay, so immediately necessary care and urgent care. Just a quick definition. So immediately necessary care, life-saving, or will prevent a condition becoming life-threatening and prevent serious damage. Maternity care is included in this. It's always immediately necessary, and everything else is based on the treating clinician's decision. And I can't stress enough that it is the treating clinician who makes this decision. And that it is always an individual case decision, except in the case of maternity services. So immediately necessary, given, and then think about charging afterwards. Similarly, urgent care on the next slide. I think we are. Now this is interesting because urgent care is defined as care that can't wait till the person leaves the UK. It does take into account pain, disability and the risk of the delay exacerbating their condition. So it is a more flexible definition, and I think maybe you might have feared. The overseas visitors manager is expected to establish a date they're reasonably expected to leave the UK. Very difficult. Undocumented migrants, it's very hard to know how long the process would be, even if they are deemed that they should be leaving the UK. And the advice given is that Trust may wish to estimate that such patients will remain in the UK initially for 6 months. And so that the rule of thumb is that if you're not sure that it could reasonably be a 6 month, and it's on that basis that the clinical advice would then be given. And importantly, it's not a fitness to fly test. So fitness to fly does not influence the decisions on charging and what is urgent care. Okay. Next one. There we go. So best practice, asylum seekers and refugees. Now, obviously, we talked about not asking about immigration status. So I think it's if you're clear about, if you know your patient is an asylum seeker or refugee, it is worth helping them by stating this. But again, it is really the referral that matters. And if in doubt, just no, don't become involved in the immigration status. And again, similarly with modern slavery or trafficking. Trafficking, I'm going to jump through trafficking here, but if you do suspect slavery or trafficking, then obviously talk to your safeguarding lead for advice, and do remember that we are in a position to identify trafficking, and in particular remember to use of translator. If you're in any doubt at all, don't accept the translator who comes with the patient. If you're anyway at all, in the clinic we use interpreters for the clinical part of the visit, and do query, try and talk to people on their own, have notices where and ways that maybe people can indicate that they want to have a private conversation. And I think that's all. I'm sure you have considered this and been to other trainings to do with trafficking. So just a quick mention here. Danny, let's move on. So let's quick look at the chat. I'm going to change tack now. So if anybody does want to ask any questions, we're sort of nearing the end of the presentation, but okay. So if in any doubt, I think now we'll just consider, how did that happen, right? We're going to consider why. Sorry, Danny, are you okay with the, there we go, lovely. So we're going to consider, why should we? There's plenty of, you may find yourself in the position of having this debate. You may already be having the debate within yourself. Firstly, actually, let's move through the slides. There are four areas to just look at here. It's a human right, and it's embedded in the NHS Act, as shown in the next slide. Which, lovely. And I think that just like to highlight the NHS value here, medical ethics and principles, that everyone counts, make sure nobody's excluded, discriminated against or left behind. And I think most people, and certainly who join the health service, have done so on this basis. They know it's an NHS based on clinical need, not ability to pay, and that has been enshrined, to use the word, in the NHS since its inception in 1948. And I think it's something that for most of us we don't want to lose, and it is a human right. Okay. So public health, importance of vaccinations, importance of public health measures, so engage everybody, travel health, migrant health, TB, preventative health, possibly not highlighted in the next slide. Well, I'll talk about it more now, but preventative health in its wider sense. We see untreated hypertension, we see high blood sugars, we see early and not so early presentations of chronic diseases, which should have been managed before. Women we see have not been having cervical smears, they've not been having breast examinations. I've seen telephone consultations with 2 or 3 women with breast lumps needing urgent referral, 2-week wait referral, and since in the last 6 months, and so it just makes good sense that these conditions are not left. And in fact, I think in the last 6 months, I have telephone consultations, advised A&E immediately for 2 of the people I've spoken to, both of whom I think, if they had not, were at the stage they had not been seen, had been getting progressively worse, they should have been seen earlier, and if they had not been seen, I think they would have been admitted in a sort of life-threatening stage. Mental health, obviously important. Many of the people we see in the clinic are suffering from mental health conditions. We see and mental health conditions, effects of trauma. Many have been traumatized, many are suffering from effects of trauma and are in unstable situations which worsen the situation that they are in, worsen their mental health condition. Danny, if you can pop them again. Okay, then cost effectiveness. This is, I'm afraid this is the slide from 2012 to 13. So the bigger circle will be even bigger. I don't know about the smaller circle, that would be bigger. I'd just like to highlight the fact that this 1 point something percent of the total bill actually looks bigger than 1 point something percent, but the estimated cost in 2012-13, and this includes here the estimated costs of EEA and non-EEA visitors, temporary migrants, students, British expats and others. So it's a pretty small proportion of the total bill. There is no good cost-effective evaluation assessment reports. There are no good cost-effective assessment reports available, and it's not, so this doesn't take into account any of the administration and other costs of the service. Jumping to the next slide, which is the last slide. So this is just to give you again the website for joining Safe Surgeries, and I would recommend the Doctors of the World website. It's got a lot of useful resources. We've got about, according to me, we've got about 3 minutes. So if anybody,
yeah, there was a question in the chat, Thelma. I can read it out. From Sapna.
Yes.
Those visiting for holiday and have forgotten their medication in their home country, do we have to write an FP10 or do we do a private prescription?
Right. Yes. So if they need the prescription clinically, then it would be an FP10. And if they're seeing you, as GP.
Okay, great. She said thank you. And that was all on the chat, but I'll collate the rest from the other session and we'll send the Q&A document out.
Okay. Right. Well, apologies for the slide. So I have no idea what happened at the beginning, losing the slides, and I'll send the slightly updated version of slides to you, Danny, which, in any case. Okay.
One more. Yep, that's great. Yep, that's fine. Then I'll circulate the slides and the Q&A document and everything else to everyone that attended and everyone else that couldn't attend too. Thanks a lot, Thelma.
Great. Lovely to see you all, and I hope it's been of use. Bye for now.
Thanks, Thelma. Bye.
Bye.